Hello there and welcome. We are here on Module 1, Training 7, and now it is all about pharmacokinetics, right? It's important concept. We'll delve a little bit into inhibitors, inducers, acronyms, get you ready for the board, so let's waste no time. Here we are. This is our roadmap, and here we're covering pharmacokinetics. So, what is pharmacokinetics? Simply is what the body does to the drug, right? And that is through absorption, distribution, metabolism, and excretion. And then you can remember ADAM, ADAM for absorption, distribution, metabolism, and secretion. I often see test questions coming up on this subject that will not be what the body does to the drugs, but it would be which of the following um, produce the such symptoms of a drug absorption, right? Or excretion, or so forth, then the answer would be pharmacokinetics. So get in the right set of mind to learn a little bit deeper than what's just in here. So a little bit deeper, okay? So pharmacokinetics is what the body does to the drugs and is concerning absorption, distribution, metabolism, and excretion. So absorption, right? Simple concept. This occurs in the small intestine. Is this the drug moving into the body? Distribution, right? The amount of medication absorbed by the body depends on the patient's condition, the type of drug, and the route of administration. Distribution of the drug in the body is affected by the amount of muscle and fat. Anyone surprised here? No, right? If you have the protein bound, they can attach to your muscles, or the amount of fat obviously affects your distribution. Now, when it comes to metabolism, the drug is broken down in preparation for elimination from the body. And that comes the first pass effect. We are talking about the recirculation process, the uptake and conversion by which the substrates change the drugs and are simply reduced by the cyclo cytochromes P450. Okay? Enzymes in the liver and after the enteric absorption. Non enteric routes of medication bypassed by the first pass effect. Okay? So, metabolism, the drug is breakdown, and then you have the first pass effect. Excretion is the process by which the substance, the drug substrates or toxin, leaves the body, and that is through feces, urine, and skin. Now, let's talk about pharmacokinetics, right? And we said the pharmacokinetics is what the body does to the drug. Pharmacokinetics half a life. Okay, the half a life concept is important. Questions can be given to you and ask you in regards when would you expect the drugs to be out of the body. And simply put, this is a very easy to understand subject. So let's say a drug has a 10-hour half life. So when 10 hours has passed, now the drug will be 50% of the original dose. When another 10 hours elapse, then it will be 50% of 50, and so on until the drug is completely eliminated out of the body. Yeah? So the time needed to clear 50% of the drugs from the plasma, a steady state is achieved in 5 half lives and 5 half-lives are required to eliminate the drugs from circulation. Now, this is give and take, right? Some people say 5.5, 6 half-lives. So basically, the amount of drugs that are taken by the body and eliminated, and you achieve steady state if you take the drug and the amount of it you take the drugs and the amount that eliminated stays the same. That's when you achieve a steady state. Now, substrates interactions can change, and that is now when we are talking about the inducers and inhibitors, right? That's a very important concept. So, substrate interaction can change, and that means the inducers or inhibitors of the CYP for 50 metabolism, which change, decrease, or increase the volume distribution or the concentration. So, what is an inducer? Inducer, it speeds up the metabolism. And if it speeds up the metabolism, it decreases the serum level of the drug. So, I like it, simple concept, keeping things as simple as possible. Inducer, I think in my head, this is a room full of people, and I want to induce them out. I want them to go. Therefore, I have less people in this room right now. And that means, in the case of the drug, if I have less of a drug, I may have a sub-therapeutic effect. And that's what inducer is. It's the speed up of the metabolism, decreasing the serum level of the drug, which could cause a sub-therapeutic amount on the patient. So, what is your action? Your action is to bring the patient to a therapeutic level. So, here, for example, right, we have the chemicals in tobacco smoke, okay? So, which accelerate the metabolism of a clozapine or alozapine and alozapine. And that's by inducing the CYP chrome 450 1A2. This is important. Know that cigarette smoking can be an inducer of clozapine and alozapine. And the CYP involved is 1A2. Okay, so it's an inducer, affects clozapine or lozapine, and the CYP involved is 1A2. Okay, so what happened here is lowering, since it's an inducer, it lowers the drug blood level. On the other hand, blood level of clozapine and alozapine can rise significantly within days of quitting, right? Or reducing cigarettes. So, guys, what I'm saying here is simple as this, right? A patient smokes the 1A2, the CYP, smoking, right? Smoking away. So, therefore, it's an inducer of the drug. The drug is the practitioner may need a higher dose because the amount of the drug in the system is being eliminated. Now the patient says, "Hey, I want to stop smoking," and you're still giving the higher dose, right? So the amount of staying drug now is a lot higher. So your action is, if you don't have enough drug concentration, you increase. If if the patient stopped smoking, you decrease the drugs due to the CYP 1, 2, 1A2. Okay. Now, what are the inducers? There are several inducers, several of them. But a simple way to memorize, you could use this S bars, which is St. John's Wort, antiepileptics, and that's your phenytonin, the phenobarbital, oxycarbazine, and the carbamazepine, rifampin, and smoke. These are your inducers. I'll show you another list, but let's remember this. Okay, so this is your inducers. You can remember inducers by the acronym, okay? Acronym drop, act, scam, GBS, which stands for the Latin re, uh, reframptin autoconceptive pills, or OCPs, phenobarbital, phenobarbital, antivirus medication, carbamazepine, tobacco smoking, um, sulfur renuria drugs, clozloaspirin, alcohol if it's chronic, methadone, antifungus medications, barbiturates, and sunshine worth. So, do you have to memorize the inducers and inhibitors? No. I would suggest for you to memorize one, and I like the drop, act, scam, GBS as your inducer, making less of the medication available in the body. If you have a medication and they are using any of those medication described here by the drop, act, scam, GBS, you will have a subtherapeutic level because they are inducers of other drugs. So you may ask, well, if inducers keeps less of the drug in the body, what does inhibitors do? It does exactly the opposite of inducers. So inhibitors, on the other hand, cause a higher drug level. Inhibitors could pose a threat to your patient because now it's inhibiting, right, the drugs from leaving the body. Therefore, you have more of the substrate in the body. And I give you an example here. So here, just focus on the inhibitors. So you have a substrate, let's say 3 little balls here, plus one inhibitor. Look to the right here. How many circles do you have? You have 5 little balls left over. So that's a lot more than you thought. You started with 3, but because it's an inhibitor, now you have more in the body. Therefore, you could be risking a toxicity level. So inhibitors, more of the medication could cause toxicity levels. Okay. Don't forget this concept. On the other hand, inducers, right? So you have less of the medication in the body, so it could cause a subtherapeutic effect. And you always have to make sure smoking, clozapine, alozapine, and your CYP interaction. Now, if you want to memorize the inhibitors versus the inducer drugs, you can use sakefaces.com, and that's your sodium valproate, isoniazide, clamidine, uh, ketoconazole, and the rest. You get it. I would say memorize this, one of them, and sort of, um, if it doesn't fall within your list, you can pretty much assume it belongs to the other list. Ideally you'd memorize both, but I would save that your brain power to other subjects as we have a lot more to cover. Now, key concepts to remember, right? The 2C19 is reduced activities in 20% of the Asians and 19% African Americans. 1A2, that's the inhibitor of SSRIs and induced by the cigarette smoking, which affect alozapine and clozapine elimination. So it inducing less of the medication in the body you need to increase. You have a 2D6, that's your Caucasian folks are often poor metabolizer, and that would include your fluoxetine, your Prozac, um, your paroxetine, and your bupropion are strong inhibitors there. So, uh, 3A4 is inhibited by SSRIs. So you have induced by clozapine, impacting oral contraceptive levels. Okay, so in summary here, inducers cause low serum level. Inhibitor cause high serum levels. Okay, and smoking and the dose of med, that's important. It's been repeated several times because we see this in practice a lot. Smoking is a strong inducer. Smoking increase the drugs, uh, decrease the drug, increase the drug metabolism, meaning breakdown of the drugs, and may need to have a higher dose. So if the patient stops smoking, then serum levels will rise, increase. So continually assessing for smoking cessation to adjust the medication as needed is your priority. So other facts that could affect the metabolism, and that means age, right? Young children have a rapid metabolism, lower drug concentration, while older adults have a lower metabolism, which means higher higher risk of toxicity, right? So younger folks have a rapid metabolism, less of the drug is in the body, while the older folks they keep most of the drug in the body due to low metabolism rates. So, specific to elderly, right? Specific factors, a decrease of intercellular water, a decrease in protein bind, a decrease in muscle mass, and reduced metabolism, right? So these are characteristics of the elderly population. However, they have an increase of body fat. The only thing that's increased is the body fat. Everything else is decreased. And that's something that you should know because it's very specific to the elderly population and how it affects them specifically. So, as we move on this module here, it's important to discuss the physiological integrity of the patients, right? The body organs, starting with the liver, how the liver can inhibit enzymes and increase the risk of drug toxicity through the first pass. If you have someone with liver damage, right? So the liver can't do the cleanup, which is its job. So therefore, more of the drugs would be inside of the body, unable to leave the body when expectant. So someone with liver damage would cause inhibit the enzymes and increase the risk level of the drug. Now, if we're talking about the kidneys, the renal insufficiency or acute kidney disease, the same concept applies. If the kidney is unable to produce its effect as it should, if it's not able to work well, then you have a higher drug concentration. So it can result in an elevated serum concentration due to the reduced GFR. Okay, so when you look at the GFR, look at your labs because they'll say African Americans, this is the normal. Whites, this is the norm. So just look for the normal GFR. If it's reduced, it could mean renal injury. So kidney disease or medications that impact renal clearance, such as NSAIDs, ibuprofen, thiazides, ACE inhibitors, with lisinopril there, right? May heighten serum concentration of drugs executed by the kidney. Which drug specifically I am mostly concerned about is lithium, lithium, lithium. If you have a patient taking lithium and they are taking any kind of ACE inhibitors, any kind of ibuprofen, any kind of uh, NSAIDs, right? So you would expect the lithium level, at least in theory, the lithium level to elevate because of those drugs, right? So think about it. If lithium and any medication that affects the blood pressure could cause an increase in lithium levels. Another thing to think about is the nutritional status, right? If you have someone with low muscle mass, reduced protein, increased fat storage, it can lead to an increased drug concentration and risk toxicity. Who am I talking about here? We're talking about the elderly folks, right? We just went over this um, characteristics in a second ago. Also, the increase, oh, also the intracellular volume, it affects the drugs, right? Affecting the drug concentrations reduced by in the elderly because they have a reduced intracellular volume, but increase in pregnancy potentially require dose adjustment. So it makes sense. So the elderly have a decreased intracellular volume, and pregnant women they have an increase because they actually have more of a blood volume, right? Intercellular volume. So check on learning. Remember that certain aspects make older folks, older adults more prone to drug toxicity. What is the crucial factor to take into account when treating them? Is it A, reduced body fat? Is it B, enhanced liver capacity? Is it D, diminished protein binding? Or D, heightened muscle concentration? Which one of those goes along with older adults? Well, do they have reduced body fat? Mm, okay. They have decreased protein binding, right? Because they have decreased protein binding. Remember, everything was decreased other than the fat. The fat was increased. So the diminished protein binding, this increased the free drug concentration, making older adults more susceptible to drug interaction, right? Reduced body fat, while it can impact distribution, it's not the main factor affecting the drug toxicity in older adults. Enhanced liver capacity, this doesn't apply. And heightened muscle concentration definitely doesn't apply to elderly population, most of them. So it's less relevant when consider overall drug toxicity risks in elderly patients. All right, check on learning. A 65 years old woman has been on 900 milligrams of lithium regimen for bipolar disorder over the past 7 years. Recently, her primary care provider prescribed hydrochlorothiazide 12.5 milligrams daily due to hypertension. She now experiences muscle weakness, ataxia, nausea with lithium level of 2.0. Which drug interaction is most likely responsible for the mentioned symptoms? Is it due to low potassium level? Is it due to the low sodium level? Is it due to the accelerated removal of lithium by the kidney or slow removal of lithium by the kidney, which means reduce renal clearance? Well, if you guess reduce renal clearance, so slow removal of lithium, you guess correctly. Remember that every time you have a patient on NSAIDs, ibuprofen, any drugs that affects the blood pressure, your ACE inhibitors, right? It will have an increase in the lithium levels. So this results in a high lithium concentrations in the body. Increased lithium levels can cause muscle weakness, ataxia, and nausea. Okay? And the other options are incorrect because it does not answer the question. option here that says accelerated removal of the kidney, right? It will increase renal clearance. This would lower rather than rise the lithium level in the bloodstream. And just like that, today we learned about inhibitors, inducers, how the elderly most likely body composition affects the drug. Lots of good information. Make sure you memorize one of the acronym covered. I'll see you on the next training.